Good morning, good afternoon, or good evening, depending upon where in the world you are. I am Eric Rubenstein, and for those of you who have not yet sat in through on one of my podcasts, I am Advize Health's Director of Litigation, Fraud, Waste, and Abuse, and I'm going to call this Retro Fraud a special edition. My guest today, as you can see on the other half of the screen, is Karen Weintraub. Karen is the vice president, or one of the vice presidents, at Healthcare Fraudshield. I've known Karen personally for about 20 years from her days as an SIU investigator in New Jersey, back when I was an OIG agent. She's a very close personal friend as well as a great professional contact. And Karen and I are going to talk a little bit today about AI in the fraud, waste, and abuse data analytics space. But really, we're going to talk about the sort of that full spectrum, taking it back to the retro fraud world, about how AI is really in a vacuum, and it's not really AI. It's AI with a human intelligence piece. So, Karen, welcome to my podcast, and tell us a little bit about Healthcare Fraud Shield and what you do there.
Thank you. Thanks so much for having me on. It's always a pleasure to have a conversation with you about fraud and other things. Healthcare Fraud Shield. We've been around since actually really 2011. We are a fraud, waste, and abuse software solution company, and we've got a variety of different modules that we have built. It's an integrated system. So for those that look at medical claims, or look at pharmacy claims, case management tool, reporting. We look at post-payment, we look at prepayment. It runs the whole gamut of a fraud, waste, and abuse solution. And I know we'll get into this in a little bit, but our analytics include a variety of things from AI to traditional rules-based systems and alerts as well. Our clients are typically insurance companies. We work very closely with payment integrity, special investigations units, and several other types of departments as well.
Great. And so I know, as time has gone on, when I started and you started, the big focus was not really on data analytics, because when you and I both started in the early 90s and mid 90s, the ability to do some of the more robust data analytics that are currently out there, that are sort of those rules-based systems, taking the NCCI, the medically unlikely edits, and then just some of the plan edits that may be in place, things that are out there now with geospacing and geofencing, and the unlikelihood of a patient in California getting a prescription from a provider in Florida for a prescription being filled by a pharmacy in Maine, and being able to do all of that pinpointing. Back when you and I started, none of that existed. It was billing histories that would come out in the early versions of Excel, which had limitations on the number of lines and the number of fields. And if you had the ability to do a pivot chart in Excel back when you and I started, you were an Excel guru. Now that doesn't seem to be the case. And then there was this tectonic shift towards AI that occurred probably post 2000, 2010, when that really started to percolate up. And now we're seeing this sort of hybrid model where it's not just about data analytics, and it's really incorporating data analytics with that human element, because there are things like false positives and false negatives and things of that sort. Tell us a little bit about what you see as being some of those trends that are going on in the industry.
Sure, absolutely. So, yeah, I mean, years ago, either people didn't have a system or, there was probably two systems available 20 years ago, and they were rules based. And you had to know what to tell the rule to do. So, when AI started to come around, a lot of companies started focusing on just AI. And there are companies out there that still focus on just AI. At Healthcare Fraud Shield, we focus on AI as well, but we still have rules, and we do believe in a hybrid model because all of it requires different aspects to determining what's accurate or not. So that human element still exists on the rules side, still exists on the AI side. We've got a terrific team of data scientists who have come up with a variety of models. But when you look at and you vet the data, to your point, there can be potential false positives, and that can be for a variety of reasons. Every client's data is different. Not every data is normalized or or the same across payer to payer. So different examples that you might see. An AI output could be something that looks like an anomaly, but someone who knows the data and can dig in can determine, oh, well, that specialty is wrong in the payer's data for some reason. So it looks like an anomaly because they have bad data. Or maybe their specialty is right, but maybe they have subspecialties that you were not aware of. Or maybe there's a contract that tells something more of the story. So that human piece is so important, just all around, both AI and a traditional rules-based system.
Yeah, I think one of the things when the healthcare strike forces came out, some of them, sometimes people call them heat, health enforcement teams, but it's really the strike force. When I was an OIG agent in my last, say, 6 or 8 months working there at the OIG in New Jersey, the strike force came to New Jersey, and oddly enough, in most areas, the strike forces are relegated to certain areas because they're based upon like a zip code or a hotspot. When it came to New Jersey, somebody apparently decided that the entire state of New Jersey was crap and decided to make the entire state a strike force. But one of the very first cases that I had that came through the strike force, and by the way, for those that don't fully understand how the strike force works, the strike force is reliant very heavily upon data analytics as its starting point for cases. Whereas in traditional healthcare fraud, as you know, Karen, it's a combination of things that are proactive, reactive, complaints that come in from members, complaints that come in from employees, former employees, current employees. There's a variety of ways that complaints come in. I do a ton of training on the Advize Health side about sort of OIG operational things, and without giving away the store, I talk a lot about how the sort of the complaint process. But one of the things that the strike force relied very heavily on was data analytics that come in through the contractors that the government uses strictly to identify sort of on the onset the low-hanging fruit. And one of the first cases I ever got with the strike force involved a doctor who was a neurologist, who was one of the highest billers. I think she was the highest biller in New Jersey and maybe one of the top 2 or 3 in the country for allergy shots. And she's a neurologist. And so she spikes as an anomaly for those. But the thing that was also interesting was she also was an anomaly with respect to her referrals for pharmacy prescriptions. And so the prosecutor on the case wanted me to look at and investigate very thoroughly, mind you, because that's how it has to be, the relationship that might have existed between this neurologist and 3 pharmacies that were in question. And the prosecutor was convinced that there was a kickback arrangement between her and the 3 pharmacies because some ridiculous number, like 98 or 99% of all the patients were going to one of these 3 pharmacies. And from a data analytics perspective, it looked terrible. But the human element was that it really took me a day to vet this out and realize a couple things. One, the 3 pharmacies were all within about a 2 or 3 mile radius of the doctor. Two, the patients all lived within a few mile radius of the doctor or the pharmacy. Next, the top handful of drugs that each one of those pharmacies dispensed based upon the prescriptions from the doctor were the same drugs. And so what there really was just a convenience. It wasn't like one pharmacy was paying. There might have been a kickback arrangement, but if you're going to focus on anything, you focus on the fact that the neurologist is billing for the allergies. And I think, that sort of got to the heart for me of the argument that data in and of itself is a vacuum, and that you need to look at where that relationship lies. Is it a false? In that case, I think it was unequivocally a false positive. Now, the doctor's issues involving being a neurologist and allergy testing is another story that led to charges being filed against the doctor, and a trial is ensuing very soon on something like that. But talk a little bit about how you guys come up with, identifying these things and vetting out your false positives.
Sure. Yeah, I mean, we could talk stories probably for hours about all the things that you see. Well, I'll give you some false positives from a few different perspectives. So, one, even just from traditional rules, very commonly, and I've seen this in many instances. So I use this example a lot. So for those who have heard me speak before, I apologize. I'm going to use it again. But a lot of companies who do kind of more of a traditional rules base will look at things such as evaluation and management codes. So when you look at those codes, you've got 5 different codes that represent established patients, the highest code being 99215. And people usually flag providers who are the highest level of those codes. I have seen, I can't tell you how many times where a software system flags it, and then you talk to the client about it. Oh, yeah, we know that's this provider. They have a special arrangement. They only bill that code. I've seen that with all kinds of different providers and provider contracts. The same thing can happen in AI though. Now AI, we're not telling it to look for 99215, but it detects maybe that 99215 is involved in some anomalous behavior. But similar concept, unless you actually know the data, know the contracts, know the providers, know exactly what's happening, you can't always trust the data from the get-go, until you do that additional vetting. So AI is great. Rules are great for different reasons. There's pros and cons to both, but you still need someone to who understands investigations, who understands healthcare, who understands fraud, and then all the individual nuances of your respective organization to really know if that's something you can pursue or not.
It's interesting you say that because so we've got some client that we're working with right now who constantly getting audited, constantly under a prepay. And after a little bit of digging, one of the things that I learned was that when this provider started their practice, they were an internal medicine doctor. And when they started their practice, they were just by themselves doing the work. And over the years, the practice grew, purchases were made, mergers, acquisitions. And now the practice essentially is a multidisciplinary practice. So there are neurologists, there are cardiologists, there are, whatever you can think of. There's probably 8 or 9 doctors in the group. The problem is that the provider never did anything to change their specialty. So they're still listed as an internal medicine. So now the claim goes in with that group number and it's for a neurology test. It's for, some sort of nerve conduction study or cardiology, carotid artery sonogram or something like that, and it gets flagged because you're an internal medicine doctor. Internal medicine doctors can't do a global billing with an interpretation and report of a nerve conduction study. You're not a neurologist. How do you bill for that? You're not an independent diagnostic testing facility where you can bill for it. And so the provider constantly gets flagged. And after looking at the documents and being like, we don't understand why you're getting flagged, then the conversation ensues. Wait a minute, what's your specialty list code as listed with Medicare? And then you look and you realize, hey, it's listed as internal medicine. You go, well, we can't say for sure that's why you're getting flagged, right? Only the UPIC or the MAP will know for sure. But hey, this could be one of the reasons why you're getting flagged. Now, you could be getting flagged for a lot of other reasons. We're not looking at utilization necessarily to say, hey, what's your utilization management? What's your revenue cycle like? What your peers do, what are your peers doing? But I could certainly say, hey, look, if you're listed as an internal medicine doctor and your peers are also internal medicine doctors and they're not billing for neurology tests like nerve conduction studies, and you are, hello, you're going to be flagged for that. And so that's one of those examples where I say, look, the human element is super important because now you need to have that intervention to say, hey, payer, what can we do to change our designation from internal medicine to multidisciplinary? Because maybe that'll get us off of someone's, a bad provider list. And I think that's sort of another one of those examples where, that human element is very important.
Yeah, I'll take it a step further. So not only does the payer need to be made aware, but then if they are using a vendor, and whether it's Healthcare Fraudshield, another vendor, the vendor also should be taking a proactive approach. So personally, I'm one of the people that's involved in going through the data and realizing, well, this is flagging, but there's a legitimate reason for it, and tweaking, whether it's working with the data science team, this needs to be tweaked because of this reason, or working on the rules side, this should be tweaked, or maybe these providers need to be excluded from very specific types of analysis or rules because of their setup, or because they're specifically contracted to do something, or because they're contracted to only bill one code no matter what they do. There's so many nuances to how it's set up that varies again from company to company, that you need someone
Right.
with a detailed eye to be able to look at all of it. And it's ongoing. It's not just one and done. You don't just look at it and say, oh, I'm done, I don't need to look at this again. New providers, new contracts, new regulations, new codes. It's just a constantly changing environment.
Well, in that same vein, that's really where, when we're having conversations on our side at Advize with clients about compliance and proactive work, I say all the time, like, are you guys looking as a practice at your quarterly trending and your yearly trending? And the example I always love to give is ophthalmology, because ophthalmology is such a niche work that you can say, hey, I'm a general ophthalmologist, but I just brought in a specialist who's a retinal specialist. And so there are going to be things, whatever those things may be, items, services, procedures that a retinal specialist does that a general ophthalmologist may not do. And so all of a sudden you go from never billing a single CPT code for whatever to all of a sudden billing it every day. And I say to our provider clients, you have a likelihood of getting flagged. Now, that's not necessarily your fault, because it's not your responsibility to start telling your payers, hey, I have a retinal specialist. Ophthalmology is a specialty code. And whether you're a retinal specialist or a general ophthalmologist or a corneal specialist, it doesn't get differentiated. Similar with orthopedics, right? You're a shoulder person or you're a wrist doc or whatever it may be. It's not separated. And so I say to the people who are looking at this stuff from a revenue perspective, what's your quarterly trending? What's your yearly trending? Because what's going to happen is you're going to be an outlier. An outlier is detected through the AI. It's just the mechanical function of the data being churned. And then someone is going to look and say, ooh, hey, there's a problem here. And it's really up to a good investigator to say, like, what's the issue? It doesn't mean it doesn't need to be further vetted, but I always say that the AI and the human element on the provider side is equally as important on the provider side. The payer side, it's obviously an important piece, because you don't want to do, when I got into the consulting world and I suddenly learned the phrase provider abrasion. I didn't know what that meant when I was an OIG agent, because I don't think that we really cared about provider abrasion. If you committed fraud, waste, or abuse, then you needed to, pay the piper, however that may be. But obviously, in the commercial, on the consulting side, on the provider side, that's a real thing. And so, I've said, look, on the payer side, they're doing their data analytics, they're doing their AI, they're putting in that human element. On the provider side, I said, you need to do the same thing. If the OIG and commercial payers are looking at quarterly trending and yearly trending, you should too. Know where your money's going, know where it's coming from, know who your payer mix is. Understand that if you suddenly see an uptick in income, where is it coming from? I can't tell you how many clients we've had. So we had one client in particular who had to make a self-disclosure. She was an endocrinologist, and her patient base never really changed. Um, Same patients that she was seeing, same volume of patients, same census. All of a sudden, her income went like this. And it was because she was told, she brought in a new revenue cycle management company and practice management company who told her, oh, we've done some tweaking to your claims. You weren't really doing it right. And we did. Really, what they were doing was they were systemically going in and upcoding her claims, because they were being financially, there was financial remuneration based upon the accounts receivable. And so it's like, do you just abdicate the throne, or do you take your, clearly when you're getting all of this money, that's your AI, right? You've got all this money coming in. You should be, your human intel piece is what's causing it. And I think that's where, on the provider side, I think that's where they miss the mark oftentimes.
No, I would agree. Look, our job is to help people find things that aren't done right. So I'm always a big advocate of, whether you're talking to providers or talking to payers, the goal is to just make sure it's billed correctly. So, I mean, our job is to help, obviously, the payers identify what may not be billed correctly. But their job is to look at it further. In some cases, they'll, maybe we'll do it for them as well. But unless there's some specific scenario that you're monitoring on a prepayment side, which you can still use AI on prepayment, although you may just want to, you already know this is a problem. Let's just look for this and stop it. But really, again, the end goal is let's just make sure it's right. Um,
We see with some of the payer clients that we have, they always come to us and they say, well, can you help us with coming up with some sort of methodology where we can auto deny certain types of claims in the absence of medical records? And there's probably a very small niche of things that you can do that. Like, one thing that comes to mind immediately is if you go to an emergency room and the emergency room group bills for a level 5 and the hospital bills for a level 4, I would say, hey, there's a problem there, right? When you don't have matched claims for your facility and your provider charges. But I think that generally speaking, the ability to auto deny certain things can have a backfire effect. Like, I know that there are some plans out there who have a routine practice of auto denying level 5 emergency department services, just routine denial of them. And I get that, right? Like a level 4 or level 5, you've got to be close to death or dead to have a level 4 or a level 5. But the negative of that is if you're the emergency room group and you've now got $1 million in claims that have been denied because they're not downcoded, they're just flat out denied, and you want to appeal them, there's a cost incurred for everyone. And so I don't know if that's a great example of, how you meld it, but, I can see that a little bit of the trend is, particularly with things like E&Ms, CMS for years has been looking for the ability to be able with AI to ingest large volumes of E&M documents from providers to audit E&Ms in the absence of a human. The error rate on E&Ms, I just saw something recently, it's something like over 40% on E&Ms. And just in the February 2020 CERT audits that were done, there was a 9% error rate on E&Ms, which equated to something like $8 billion or something absurd like that. So I could see that there's this desire to move that way, but in the absence of having a medical record, the ability to properly appeal a denial in which, I've never understood this, but how is it that you are asked to produce the full medical record, you get denied, but on appeal, you can produce other documents that support that service? It's like if you just provided that to begin with, maybe we wouldn't be where we are. But where do you see some of the future stuff going as it relates to AI and that human element that's kind of the important piece of the puzzle?
yeah, I mean, I think it's just going to continue to grow in the sense that one of the things that you're seeing more with AI is just the speed at which it can detect things, which um, again, with everything, it just all evolves, technology evolves. So the ability to use AI to target things faster, create models faster, which in turn relates to vetting it faster. We're working on a lot of different things, incorporating AI throughout actually our entire solution. So I think you're not just going to see it in just in just the broad sense of the analytics of the entire population of data. I think you're going to start to see it sprinkled throughout different types of data that's used from healthcare fraud detection. Again, there's pros and cons to many different approaches. You want to be careful that you don't just target one thing with AI on in one argument could be that, well, I'm going to find a lot of good stuff in that one area. But if you do that, you could also be missing a bunch of other things. So I'm seeing the industry actually explore, different companies explore, well, we're just going to target here, or we're just going to still look at the big population, or what else can we integrate into our solution with AI. And I think you're going to see it start to expand a little bit because of the ability to do it faster. So, even our organization as well, we look at the population of data as a whole, but we're also looking at some very specific areas as well. I mean, COVID, great example. COVID hit. So, the investigators in us, not just from our own experiences and knowledge, but our clients as well, we knew exactly what to look for from a rules perspective. So right away it was, all right, labs is going to be an issue.
Hmm.
All of that. We knew that.
Right.
But then you get into, well, what do we don't know? And that's where AI really becomes helpful. So we knew that there were going to be things in the COVID billing world that we were not aware of. So we actually came up with COVID models that were able to work simultaneously and run parallel and in conjunction with the rule side of it. And then to your point again, who's the person that's going to be able to look at the results and say, yeah, this is great, this is not great. So I think you're going to start to see things done faster, more variations of different types of models that are coming out.
Yeah, I mean, I think that the thing you're hitting on is what I would say is real time or near real time. You know, the ability to nobody wants to hear about fraud trends in their data from 2019 or 2018. You know, nobody wants to nobody wants to know that they had a problem in 2019. People want to know about it today.
Yep. No, I agree wholeheartedly. Um, Not to, well, I'll use this opportunity. I'll tout us a little bit, but we are working on a lot of different things, and for anyone who follows things that we've posted on social media, it's no secret. But um, being able to find things real time, not just in one client, but across all clients. And that's something that we've been working
Right.
on and are showing some great progress with, because one data set is isolated. You want to be able to look at the industry as a whole as much as
Right.
possible.
And I
And in
talk about that, and I talk about that a lot. That's really just the aggregation of data. It's taking data that is structured or semi-structured or unstructured from your different payer clients. It's putting it all together and it's aggregating it. And as you know, there are some government-funded programs that are consortiums of commercial and government data that do that to aggregate to come across. But again, it's not real time or near real time. And so the question becomes like, what is the probative value? Telling me that I have a provider who is an outlier because on their E&Ms, they're an impossible day for 6 plans that are aggregating data to one location, but it's from 2019 or 2020. Well, that's we need real time and near real time. And we're not a data company. We don't build it in a mousetrap. We incorporate data from other sources. But what you guys are doing is innovative because, well, it's not innovative in the sense that you're doing something that's out there in some regards, but you're doing it with your client base using your innovative AI approaches and all of that. And so that makes that unique because now a payer client of yours who may not have what they consider to be a problem or what you may not consider to be a problem is showing as a problem. The E&M or any of those timed codes. We would see that when I was an OIG agent. We would get these cases where it would be an impossible day, and we would say, "Well, hold on, it's an impossible day just on the Medicare. Imagine what it's like across." And that's sort of where in the pharmacy world, when PBMs do audits, they're only seeing their little microcosm of life. And so when a PBM goes into a pharmacy and says, "Hey, we're doing an audit. You billed us for 100 aspirin. Show us the invoices for 100 aspirin." And the pharmacy shows them invoices for 100 aspirin. The PBM goes, "Great, you get a check mark on that." Now a week later, another PBM comes in and says, "Hey, show me the invoices for 100 aspirin," and it's for the same time period. And the pharmacy goes, "Here are the invoices for 100 aspirin." And that second PBM goes, "Hey, great, you guys are good." Well, both of them couldn't have done that, right? And so that aggregation of information and data is really that, sort of that push off point. So it's kind of cool to see that. And I would love to hear, in some future time, like what sort of results you guys are seeing with that. Because I do think that is the wave of where analytics needs to go. The days of a plan keeping their information proprietary is going away with transparency. And so one of the big issues on that aggregation of data has been sort of that pricing proprietary nature of stuff. But you can remove that. Like, at the end of the day, one plan versus another, I don't really care if you paid $50 or $30. I mean, I care from a contracting perspective, but if I'm an SIU person or a fraud person, I want to know, if Dr. Rubenstein billed me for 7 hours and then billed another plan for 12 hours, well, that's a problem. And I think that's where the analytics really comes into play, is in that aggregation. And I think you guys doing that is going to really start to pay those dividends on who the fraudulent providers are. I mean, the waste and the abuse providers are the ones you can change behavior on, right? You can change the behavior of a provider engaged in waste or abuse because they just may not know or whatever it may be. But those intent on committing fraud don't care about what Karen Weintraub or Rubinstein have to say. But those that you're identifying in your analytics that are in those impossible days, and maybe it's just because, hey, it looks like a 99214 to me, but it really isn't, and they just need to, understand that.
But to your point, to really be effective, where the future is going is that real time or near real time. So, I don't want to know that they had 20 hours in a day 2, 3 years ago. I want to know. So but today's October 5th. If you're looking at prepayment, great, you can do it pretty much real time. If you're looking at post payment, then you can do it near real time. Maybe I'm looking at just got September's data, and now I can do it and look at the last month and maybe stop something from happening this day, next week, next month, and really
Right.
start to have more of an immediate impact.
Well, I would say it's stopping the bleeding in a short period of time. And so the converse, when I do work on the provider side now, I say to the providers, your proactive audit cadence should be at the minimum quarterly.
Yeah.
Now, really, I would love to see people say, let's do, 30 claims a month or something like that. But, at a minimum, I say quarterly, because if you do have a problem, it's much easier to fix a problem that's only 90 days in than saying, hey, we're going to look at a retrospective audit that's a year or two old, and you find that you have a problem, and now you have a $500,000 overpayment, which you cannot make a $500,000 overpayment to a payer. I mean, you're going to have to make a self-disclosure. You're going to have to figure out what you're going to do. Under Affordable Care Act, you have 8 months to do your investigation and make your overpayment that way. But beyond that 8 months, making a self-disclosure is really the way to go, and you have to pay the 1.5 times and all the other collateral effects of that. If you're doing a cadence that's frequent, you stop, you find your problems, and you stay in the driver's seat. You fix your problem from the payer side. And I say all the time, look, the payers are doing this stuff on a frequent cadence.
Hmm.
They're going to try to stop the bleeding before it gets bad. You should be able to fix the bleeding before it gets too bad. So I always say on the provider side, it's revenue preservation. So fix your problems so you can keep your money, and it's revenue generation because maybe you identify an issue and you go, hey, we've been billing 99212, but really should be 99213. Or
Hmm.
maybe we're not bundling this test the way we should, and we get this extra money and what have you. So the revenue preservation, revenue generation work both ways on the payer side and the provider side. So it's going to be interesting to see what happens over the next couple of years with CMS's push. Um, with respect to AI, particularly in the E&Ms. It's going to be interesting to see how you guys at Healthcare Fraud Shield, as you convince more of your payer clients to aggregate their data. It's also going to be interesting to see how us on the Advize side are talking to our provider clients and getting them to buy into these regular cadences of more frequent audits, because if you frequently audit yourself, you're going to find those problems. You're going to stay off the radar. And one of my favorite phrases lately is too many providers step over a dime to look for a quarter that doesn't exist. And that's
Nice.
really, that's really the problem, is, they're saying, well, penny wise, pound foolish. I'm not going to worry about these issues until maybe I'll never have to, deal with them. And as you know, it's not a matter of if you get audited, it's a matter of when you get audited, and where you are, in that. So any
Yeah.
final thoughts?
Yeah, you just made me think of a discussion I had with a lawyer who represented providers many years ago. He looked at me and he said, "Let's face it, there's no such thing as a random audit." You know, and he looked at me and we laughed. And maybe, I shouldn't say that. There are some requirements to do some kind of auditing of, certain lines of business. You have to, payers do need to audit certain number of claims in a given time period. But usually when an investigative unit's involved, it's probably unlikely that it's a random audit.
Yep. And that's why I say, generally speaking, what a lot of the provider community doesn't know is that most payers have two sort of groups: the special investigations unit, which is the fraud group, and then the payment integrity group, which is that waste and abuse. And oftentimes you don't know who's asking for those records, so you don't know, which part of the puzzle they're looking for. But you and I could probably talk for another hour about what the differences are, and did we see? I never saw a difference. I know you don't look at it really any differently. I think people that work on the fraud side typically bundle those fraud, waste, abuse together. We don't say fraud, waste, and abuse. We say fraud, waste, and abuse. So, well, look, it's been great having you.
Thank
I
you.
love talking to you. I know I was a guest on your podcast, so this was my payback to you.
Thank you. Always a
So
pleasure.
yeah, listen, it's always great having you. I do want to have you on again so we can talk, maybe 6 months from now and see where any of this has gone and see if it's gone anywhere, or if the two of us were just pontificating for a half an hour, which is entirely possible because we like to do that. But again, thanks again for being on, and please tune in again for some future retro fraud podcasts. Again, I'm Eric Rubenstein. I'm the Director of Litigation, Fraud, Waste, and Abuse Support at Advize Health. Thanks for tuning in, everybody.
Thank you.